This is a 89-year-old woman who presented with abdominal pain, nausea, and vomiting, and a CT scan was performed to evaluate for bowel obstruction. These axial images have been acquired in portal venous phase after injection of IV contrast, and as we scroll through these images, we find that the stomach is distended, and there are multiple distended small bowel loops throughout the abdomen and pelvis. Uterus is absent, urinary bladder is unremarkable. Colon shows distal colonic diverticulosis. And the other findings include a Link's device at the GE junction, cholecystectomy, and prominent extrahepatic CBD. So, in patients who present with dilated bowel loops and are obstructed, the challenging task is to figure out where the transition point is. Proximal to the transition point, we expect dilated bowel loops, and distal to the transition point, we expect collapsed bowel loops. So as we trace this colon proximally, the splenic flexure, transverse colon, into back into the ascending colon, this is the ileocecal junction. There's always some fat at that location. And this is the terminal ileum, and we're going back following the distal small bowel. It's all collapsed. So somewhere between these dilated loops and the collapsed loop of small bowel, there is a transition point. I like scrolling through the coronal images to find the transition point. And the strategy is to go back and forth, starting from the proximal end of the tract, which is the stomach, which is distended here, more distally through the small bowel to go to the point where there is an end of these dilated small bowel loops and starting of the collapsed small bowel loops. So here we see the duodenum crossing over to the left side, the C loop, and then we're going to follow these small bowel loops distally, right? So the challenge is to go just back and forth along the length of the small bowel to try to go to the transition point. And I want to show you how I do this on this patient because the findings are classic. As we are following these small bowel loops, we find that the walls on both sides are showing enhancement. That means that there is no bowel ischemia or bowel necrosis. The non-dependent portion will have air or gas, and the more dependent portion will be filled and distended with fluid. All right, so now we are sort of halfway through the small bowel. Getting into the distal small bowel. And you can see that the entire length is just looping around inside the abdomen and pelvis. And when this gets distended, there is increased intra-abdominal pressure, which leads to evacuation of the bowel loops distal to the transition point. And so here we have reached the end of this dilated loop of bowel right there. We can see that there has been a prior anastomosis, and at the site of the anastomosis, we have the site of obstruction or the transition point. This part more proximally that we have followed from stomach to this point is dilated, and more distally it's collapsed, right? So that's the transition point in the distal small bowel in the left lower quadrant of the abdomen. So that's the way to find the transition point and to tell your surgeons where the transition point is located. For something which is hyperdense, like we saw earlier, I like looking at the scout image. So here we can see the Lynx device in the distal esophagus at the GE junction better. Also, the internal fixation of the right proximal femur is better visualized here. Thank you.